Today was amazing. What did you think?
Well, updates in hospital medicine is always fun, and I think that Dr. Chris Moriarty and Dr.
So, Dr. Chris Moraitis from UT Austin and Dr. Carrie Helsky from John Hopkins did a mind blowing, amazing presentation, which was an hour long with 20 articles on updates in hospital medicine. Very entertaining. They did a good job at it.
you know what? I will start drinking more coffee because it showed 8 cups of coffee will make you live longer. Oh, then I
Exactly.
don't have to work out, I guess.
Well, I guess you'll be running for a long time. So let's talk about some of the topics which were discussed in updates in hospital medicine.
Sure.
Is there anything in particular you liked what he had presented?
You know, the interesting one that, I mean, not actually interesting. I think most of us are already practicing this, but the emphasis on the C. diff treatment.
Okay.
That, and Chris made an amazing, actually very funny joke about, no matter whether it's mother or mother-in-law, everybody gets vancomycin.
Yes.
So the metronidazole is not an option anymore. So I think everybody need to kind of default and then learn that vancomycin is the first choice. Exactly. I think that's one take home that I really liked. And obviously the other one on the same lines is the oral antibiotics. So I know that study has a little bit of limitations on the endocarditis treated by oral antibiotics, but seems like the study that is published in NEJM shows oral antibiotics are not any inferior in settings of endocarditis.
Yes.
For the patients that are like really cannot get IV. And if I remember, I think it was showing some decreased length of stay too.
It did. So the way they approached it was two studies they talked about, and it was interesting. Usually, we traditionally do 6 weeks of IV antibiotics for endocarditis and bone and joint infection. Again, these are two different studies, but basically, you have to choose the patient appropriately, and there is criteria. And you give 10 days of IV antibiotics followed by PO antibiotics for the same duration, but you need very good outpatient follow-up, and the studies actually had 2 to 3 days of outpatient follow-up a week, which I don't know where we can get it, but I think it is something to look forward to in the future. Don't you agree?
Yeah, and I like your jacket. Do you see patients with this jacket?
Well, there are studies apparently to prove it.
All right, that's what I was going to say. I mean, Chris, made an interesting point about how the attire actually makes the patients feel about the physician.
Yes, they did.
So, what's the conclusion?
So apparently the patients, this was more patient-centric data. The patients really feel how you dress up matters. And it is overwhelming. It's about 53% of the patients care about how you dress up, and also wearing a white coat matters to them. So it does affect patient satisfaction, I guess.
Seems like white coat didn't lose the power yet.
Not yet.
Okay,
Not yet.
All right. So let's keep going with the white coat. And obviously there's a lot of talk about opioid crisis in recent, there's several billions of dollars that are investing on opioid crisis. So there was one take home on opioid crisis that they mentioned. Do you remember that?
Yes. So Dr. Moraitis could not emphasize this enough. The number needed to treat for bupropion, for buprenorphine, is 50. Which means that when we look at aspirin as a primary prophylaxis, the number needed to treat is 42. So we might think 50 is not a big number, but we make aspirin mandatory versus we don't think too hard regarding buprenorphine.
Okay, so think about buprenorphine in opioid crisis.
Yes,
Okay,
yes.
all right, opioid users. Okay, so do you remember any other updates that you can think
There were
of?
two updates which I think are very intriguing. There was a study on IV fluids.
Okay.
And this is regarding, and this was interesting. They did two separate studies, and one was ED based to use whether to use LR versus normal saline. And LR was surprisingly winning, especially in protecting the kidneys. And then they took it a step further in another study and did the same study on ICU patients, and again, LR was winning. So I think as hospitalists, we should probably change our direction more towards LR. What do you think?
Well, I think that made sense, and On the same lines, there was a discussion about ACE inhibitors.
Yes, there was a lot of discussion about ACE inhibitors,
Um,
and it was three settings completely. One of which I still cannot agree with, but one interesting point he had brought up was talking about ACE inhibitors in intra-operative settings. Would you stop? Traditionally, I don't think I stop my patients' ACE inhibitors for
yeah.
elective surgery. Do you do that?
No, I think now the evidence shows that it is reasonable to stop it.
Exactly,
Okay.
and Dr. Moraitis actually pointed out to the data causing where you give ACE inhibitors in the morning, it causes more intraoperative hypotension. So stopping that matters. But there was another interesting study he had brought up regarding ACE inhibitor usage and mortality after treatment of AKI.
I like the comment where he said like whether you choose death over readmission, and the comment that was like I think the take home was use the ACE inhibitor and ARB. Yeah, it may actually cause readmission related to AKI,
agree.
but overall benefit, the mortality benefit is significant. So
Exactly.
think about ACE and ARB
Exactly.
at the
Exactly.
time of the discharge to make sure that they're on, even in
Exactly.
settings of the CKDs, I guess.
Yes, definitely. So it was interesting that 6 months after discharge, the long term mortality is longer, but the readmissions, like you said, for AKI could increase,
You know,
right?
and I like the slides that they used about the angel bringing the oxygen tubing.
Okay.
So that is basically he's trying to make a point. They both are trying to make a point that using oxygen is not useful. I mean, we always say like oxygen is life saving, but
Yes. You know, we were talking about end stage renal disease and ACE inhibitors. Let me take a step back and let's talk about end stage renal disease and anticoagulation because they had also discussed, Dr. Moraitis brought up DOACs, and there was a lot of discussion on DOACs and the literature supporting that. What do you think?
man, based on what they summarized, seems like DOAC is the future, and seems Apexaban is doing amazing.
Yes.
In terms of the outcomes. So I guess especially where I practice, there's a lot of non-compliance issues with the warfarin, and then the pain of getting the INR checked, and then all these things.
Yes.
I was wondering, like maybe the DOAC is going to be the first line choice in even
I
ESRD
agree. I
patients.
agree.
And, and that actually may improve the compliance. I want to see more data on obesity, like morbidly obese patients, and in settings of the in dialysis. But I'm already excited with the DOAC usage in ESRD patients.
I completely agree with you. I was impressed to see that apixaban was winning even in end-stage renal disease, and 5 milligrams, which we usually don't give, actually is a better or is showing better outcomes. Don't you agree?
Yeah, I think they repeated this point of like no dose adjusting, no dose adjusting.
Yes.
If you plan to do DOAC, just do full dose
I agree.
unless you actually meet the two absolute indications. So I think we need to pay attention to actually reap the benefit of these medications. You probably want to make sure that you're checking the dose adjustment indications carefully.
I agree.
I really like the point.
I agree.
Going back to that, we were talking about oxygen and use of oxygen. We see these slamming the oxygen on patients all the time. Everybody is on oxygen, and surprisingly, it actually makes me concerned that using oxygen in these settings actually can increase the mortality.
Yes.
And then he basically said, cutoff. Even you're thinking about MI, unless the patient is hypoxic with a pulse ox less than 92, you better not use oxygen.
Exactly.
That is just
True.
something that we probably need to make a habit of not doing it.
I completely
It's
agree.
very easy to do these things because it's a default. I think we have to step back and then think about, does this patient really need?
I agree. I agree. And it was interesting to see that the studies looked at MI and stroke patients getting additional oxygen when they don't need it. I'm guessing it is from the oxidative pathways. They're causing more injury and the outcomes are bad. I completely agree with you. It was very impressive what the data showed out there. And do you remember the data they talked about aromatherapy in ED?
Exactly. Well, that is very interesting. So, we get these calls all the time from the ancillary staff that hey, patient is nauseous, and then like immediate reaction. There's like, oh yeah, Zofran, 4 milligrams Q4 hour, Q6 hours. Guess what? Just an aromatherapy is as efficient as Zofran. I guess Zofran is hearing that. I
But
mean,
I love to tell the aromatherapy they are talking about is not lavender scents, right?
yeah, but still, no more Zofran. I mean, it's not going to
Exactly,
make a big
exactly.
difference.
So it's mainly the alcohol swabs. I was surprised to see the alcohol swabs and smelling them were better than Zofran. So which means that you can probably use them in the ER and maybe get them out, you think?
Oh, that might be a little stretch.
Okay. This has been just day 2, and I have loved HM19 so far. We have been coming here since years, every year. It's a great opportunity to
This is
network and
binge
meet.
learning,
Yeah,
man. I
exactly.
love it.
I love it. And when you get to see and meet so many people who have the same pains, and you
Yep.
get to vent, all of us can vent together, right?
Yes.
And you get to learn so much more. You get to fix problems. So I think it's a great opportunity. I'll be back next year as well.
Oh, yeah. You bet. I'll be here too. Thank you very much for going through the quality updates with us today.
Thank you.